So, welcome back everybody, and we will now start the second session of the morning, and we're going to hear about the supporting activities and the antimicrobial resistance epidemiological situation in the Western Balkans and Turkey. And to present that, it gives me great pleasure to welcome our colleague Danilo Lo-Fo Wong from the World Health Organization's Europe office. Danilo is the program manager on control of antimicrobial resistance. Please take the floor.
Yeah. Okay, do not touch that. Thank you, Charles. Thank you very much for the invitation, both to ECDC and EFSA, in allowing me to be here. It is my great pleasure to be back. As Marit said before, the previous meeting was in Dubrovnik in 2012. And at that time, I just arrived at the regional office, coming from headquarters, and I didn't know anybody, basically. And so right now, the situation has changed a lot. I've worked a lot with either you or your colleagues, and it gives me great pleasure to give you a little bit of overview of the kind of things that we are doing, and also for your inspiration if you see that, well, maybe we should be doing more together, then we're definitely open for that. So the year before the Dubrovnik meeting in 2011, there were two regional action plans that came out, one from the European Commission that Charles just mentioned, and one for the entire European region. And of course, most of you know that there are 53 member states in the European region of WHO, so basically twice as many as the European Union. It was very timely, and it was also the first of its kind, this region-wide action plan. It was recognizing that, specifically at that point in time, AMR was largely neglected in a big part of the region. There was no systematic surveillance in a large part. The problem itself needed intersectoral coordination, which is now widely recognized and practiced. And of course, antimicrobial resistance itself is not a disease. It's a complication of treatment, and it follows disease, it follows infections, it follows pathogens. So there's a large potential for spread internationally through travel and trade. And as it is really truly an issue of solidarity between countries, there's also a need for international standards and data and information sharing. So this was all recognized in 2011, which seems quite recent, but the global momentum that we see right now is even more recent, starting with the Global Action Plan, which was adopted in 2015. Now, even though the European Action Plan predates the Global Action Plan by 4 years, you can see here that there's a great overlap. On the top, you have the 5 strategic objectives of the Global Action Plan. To the left, on the side, you have the 7 objectives of the European Action Plan, and they're, by and large, fully compatible. So actually, for a long time, we've known what to do. We haven't just found out how to do it. In terms of implementation activities, we started, of course, mainly in the non-EU part of the region. The EU has had at least 2 decades of experience and attention to the problem, and lots of good work has been done. So we had to uncover uncharted territory in a big part of our region, which we did by starting country situation analyses. And these are very similar to the ones that have been done by ECDC and others. They start with a briefing usually at the Ministry of Health. Why are we here? What do we want to see? Who do we want to talk to? Then we have these visits with key institutions, agencies, and laboratories in the country. And at the end of a week, we debrief the Ministry of Health about what we saw, what are the recommendations, what should follow up from these recommendations, but also, importantly, how do we as WHO and partners commit to supporting you in that. In terms of implementation activities, one of the things that we really saw is that there's a lack of governance in many countries. Today, it's a One Health meeting. It's recognized that there is agriculture, there's environment, there's health, there's others. But traditionally, these sectors do not communicate very well at the national level and also at the international level. So we started a lot with policy support. We, of course, as outsiders or as a neutral organization, we have so-called convening power, which means it's easier for us to involve and invite people that usually don't talk together put them in one room and discuss the issues. We also tried to promote intersectoral coordination mechanisms. The word mechanism is a strange word, but it's basically to highlight that it could be a working group, it could be a board, it could be any kind of format where the different sectors regularly meet and discuss the issues. This particular picture is from the intersectoral coordination meeting here in Serbia a number of years ago. And actually, I forgot to congratulate Serbia on their national action plan, which was just adopted. And it's an excellent plan, and it's an excellent example for countries that are still developing theirs. And of course, national action plans. As I mentioned, we have a number of tools and templates for inspiration that countries can use for the development of their action plans. But also more recently, we've started doing evidence-based policy briefs, which is a bit more of a condensed exercise, if you will. It's about translating evidence into policy. There's a lot of evidence being gathered, but it's still difficult to sell this information to the policy makers, to the decision makers, because they don't like to read very thick volumes of evidence and information. They need very specific policy options and decide on that. And this is what evidence-informed policy briefs are all about. And there's a number of countries here that are doing these policy briefs together with us. And also at the international level, we work very closely to our sister agencies FAO and OIE for the food and agricultural side. And we have organized several tripartite meetings to discuss One Health issues. Also, a lot of resources have been developed over time, different protocols and templates, different tools, and also videos. The screenshot here is from I can hear myself. That's good. The video that was done together with UCAST, which does not necessarily replace training in the laboratory, but it's very good as a refresher course or to maintain your skills. And also through the times, we have trained a number of experts and turned them into consultants. One thing is being very good at your job, but being a consultant really needs that additional sensitivity, openness, and way of working. And we now have quite a good pool of experts that are now consultants we can work with. But a lot of it has been about training and capacity building. Of course, you do not need a national action plan to tell you that you need some capacity to build, so we're also not necessarily waiting for these to be finalized. And we did a lot of training, or starting to do more and more training on antimicrobial stewardship, which is one of the main activities that we will focus on, infection prevention and control, and also point prevalence studies to the model of ECDC. And as Charles mentioned earlier, these are the kind of activities that we would like to do with you. And the picture below is a picture from a workshop we did in Montenegro on antimicrobial stewardship last year. Also, awareness campaigns together with the European Antibiotic Awareness Day, which originated in 2008 and we joined in 2012 to expand it throughout the region. Of course, 3 years later, the World Antibiotic Awareness Week was initiated, and through this, we provide direct support to all the countries here, by the way, and also to some extent behavior change campaigns, which is something that we're still developing under the acknowledgement that knowledge itself is not enough to change behavior. And for this, we need input from social scientists, from behavioral insight experts. So how do you get from knowledge to behavior change? And this is what we're trying to find out. This is also what we're trying to support countries to do. And a number of research and demonstration projects. Demonstration projects because we cannot do it for you. Everything you do in your country, you have to take ownership. We can make demonstration programs, projects to show you that, yes, it can be done also under our circumstances, also with our resources, with our capacity. But in the end, whatever we do has to be adopted by yourself. But we put a lot of focus on surveillance network activities. As I mentioned before, in 2011, many countries did not know or did not recognize or acknowledge that they had an issue. What better way to show it than by gathering your own data? And we've heard from ECDC and from EFSA about the existing surveillance programs that are in the EU and EEA countries. But for the rest of the region, we developed two networks. one on antimicrobial consumption, called the AMC network, and the other on antimicrobial resistance, called CSER, which stands for Central Asian and Eastern European Surveillance of Antimicrobial Resistance. And all of you are part of that network, and we're very proud to have you there. In the interest of today, I will be focusing mainly on CSER activities. And I'll start with the traffic light maps that's been shown before. There's a long tradition of ECDC showing these maps, which are very good for policy making, and they're very clear, they're very illustrative of the situation. And depending on which bug-drug combination you look at, the colors change, or also over time, of course. But you will have noticed that there was a big part of the region that did not change color, which is, of course, why we started the CSER network in 2012. Now, the colors here do not depict any kind of prevalence. Basically, it's the colors of the progress of the network. So the gray countries are the EARSnet countries, if you will. The blue countries are the countries that we still needed to visit at the time and do the analysis and start working with. The orange country, in this case Belarus, was the first country that we had such a situation analysis and started working with them. And the yellow countries are those that are already able, or were already able at that time, to provide AMR data, because they were part of the network EARS before it became EARSnet. So for us, that was an instant success because they were on low-hanging fruits. And we were very happy to start off, not from scratch, but with a good body of countries. Then the next years, we started having more situation analysis. In 2014, Belarus was the first country to be able to provide surveillance data to the network, which was really an accomplishment, I think. And more countries joined over the years. And this is where we are today. Half of the countries are able to provide data to the network internationally every year. So that's really good. You can see that Central Asia is still orange. We're working very, very hard. Of course, we're trying to create a little bit of internal competition, which will be the first Central Asian country to submit data to CSER. But whoever it is, it's really important that this surveillance capacity is built and maintained. Now, we meet all kinds of, working with different countries with different settings, we meet countries at different phases of surveillance. And there's still quite a few that do not have any surveillance, and also mainly do because the foundation for surveillance is not there. They're just not taking any samples, or very sporadically. And without samples, you have no data. Without data, you have no surveillance system. So in these situations, we're doing a so-called proof of principle project, where we try to stimulate routine sampling. We train teams at hospitals. We train the laboratories in international methodology. We provide initial support, but in the end, of course, it has to become a sustainable effort. But a lot of capacity building goes in there. In the second phase, we have countries where there is no official national surveillance, but at least there's a basis to build on. And here we focus a lot on the National Reference Laboratory to take on that role of establishing and maintaining the national surveillance network, providing the training, providing the external quality assessment, etc. And in the final phase, where you have a national surveillance system in place, there is always room for improvement. So here we also try to strengthen national AMR surveillance through a number of activities, and also try to make the transition from the regional network to the global network class that's been mentioned before, and I will mention it a little bit later as well. In terms of activities, lots of training, very much focused on the laboratory, of course. Lots of systems had been outdated. There was no modern methodology, so we are introducing UCAS methodology. For those that are providing or producing data, we're introducing WHONet, supporting the network. We're putting a lot of focus on quality control and quality management, because these are not always a concept. And of course, we provide feedback on submitted data to us. Data management and analysis training is a big part of it as well. We provide external quality assessment, and here we make use of the relationship between ECDC and UK NIQUES, which have been providing these external quality assessments yearly for a number of years. And then in 2013, we also approached UK NIQUES and said, can you put additional sets and then give it or send it to the countries of CSER? And not only have more and more countries been involved in that, and more results are getting slowly better. In this particular graph, you also see there's been a shift from CLSI to UCAST, also in the countries that are working in CSER. So it's actually been a complete reverse between 2013 and 2017. Of course, also because we are supporting and promoting a UCAST methodology. And finally, we have an annual meeting, usually in relation to the ECMID, the European, or the ESCWID conference every year, where we have a national CSER network meeting, but also we are supporting national meetings every year, where countries can bring the network together, discuss the EQA results, discuss the training needs, and etc. In terms of CSER, there's an additional element that we are including. It's levels of evidence, because we are acknowledging that not all countries at this point are producing data of a similar quality. And on the one hand, we want to lower the threshold for submitting data to the network so that countries don't wait until they think it's perfect, because by sharing data, you improve the data. But we do also want to educate the reader to interpret certain data with caution. So we have three levels. The lowest level, level C, is data that's not represented for the target population, and the laboratory results are also not necessarily obtained through international standard methodology. Level B is where the data may not be representative, so there may be a bias in sampling, but the data themselves are reliable. And level A is where both the data is representative and the methodology is reliable. Now, of course, we do this to invite countries to start sharing data and to start improving what they are doing. And this is the table of levels of evidence of the latest CSER report, 2018. And you see on the left side the criteria for levels of evidence and the score, which is always done in consensus with the country, just a discussion. And the fact that it worked is that 2 years ago, both Bosnia and Herzegovina and Serbia went from level B to level A, which I think is quite an accomplishment. So also this division of level is not only helping the reader, but it's also providing a roadmap to the countries of what to improve to start producing representative quality data. This map has been showed before. This is joint data from EARSnet and CSER from this year's report. Again, there's a number of bug-drug combinations that you can look at, and we're very happy with this collaboration because also within WHO and our regional director, it's been a long-term wish to expand and to get the total picture of the European region. This is what we're working on. Now, in these graphs, the shaded countries, the ones with the lines, are the ones that are providing level B data. So also here you can see which data to interpret how. Now we started in 2012, and actually in 2014 we had our first annual report, the year after a manual, which was fully compliant with the ECDC's EARSnet. The second annual report in 2016, we made a sort of in-between report about our collaboration with collaborating centers, a proof of principle report on the work done in Georgia, which is actually another success story, if you will, because before there was not there was no surveillance. Now they have sentinel surveillance going on, which they have maintained 2 years after we pulled out the project, and they're also a part of GLASS now. So that's, I think, also a good story. And then annual report, the actual protocol came out last year, and also the last annual report. So we've been quite active. One of the other things that we're also working on is to become closer, more compliant to the global AMR surveillance system, or GLASS. And here you have the 4 specimens and the pathogens that are included. And CSER was looking at all the blood and CSF samples, and the only difference between CSER and EARSnet here is that we also include salmonella. But of course, over time, we want to include more specimens. What is important is for countries to start building the capacity to do surveillance. And of course, the most important surveillance is surveillance that is useful for the country. So these are just suggestions to to collect on a global level. So the objectives of GLASS is exactly that, to foster national AMR surveillance. That is the most important thing. Countries need to know what's going on, and they need to be able to use that data and react upon it and follow the effect of their interventions. So it's monitoring trends, it's detecting emergence of resistance, which is the benefit of collecting data internationally, and also informing estimates of AMR burden, as was done with ECDC data. So GLASS is basically, it's a system of surveillance systems, international surveillance systems, where now we started with the bacterial infections in humans initially. And last year, the first report came out of what is called the early implementation, the first 4 to 5 years of GLASS, just to see what kind of information can be collected. But also this year, in November, we saw the first global report on antibiotic consumption, and also the second report on antimicrobial resistance in humans. So currently there are 74 countries enrolled in GLASS as of 2 weeks ago. And what does that mean? First of all, you need to have some commitment from the national responsible body. They need to provide the status on your surveillance systems. And finally, if available, you need to share data. So actually also a very low bar to join GLASS. So first of all, and this is, I guess, important, you can join GLASS before you have perfect data, if you will. It's just the first thing that we're collecting is what does your national AMR surveillance system look like? And this is the example of the Republic of North Macedonia in the report that just came out. And second of all, if available, at least for one of the specimens and one bug-drug combination, you can start sharing data in these 4 specimens and population data as well. So for the first report, this is the map showing the number of countries that were enrolled. So 42 countries were enrolled. 40 of these countries shared information about the structure of the surveillance system, and 22 shared data, which is, of course, a very humble beginning. But already this year, we see that this number's greatly increased, and there's now 48 countries that are providing data, and 67 have information about their surveillance system. So a little bit about the type of indicators. It's a very busy slide, so I'm not going to go into detail, but some of the rationale behind defining these targets and pathogens and sites of infection was similar to the work done in the early days at EARSnet, just to find it out, okay, do we have an indicator of community-acquired or hospital-acquired infections? Can we pick up emergence of AMR where there are very few treatment options? And also to start using some indicators that are of interest both for humans and for animals through foodborne AMR surveillance. And the early implementation phase ends this year, so we will be reviewing and revising the setup of GLASS and to see how it becomes more appropriate, more feasible, how can we improve things. I think we're not looking for a revolution, we're looking for evolution. So we will make some changes, and for that we really need your input for those countries that are providing data and collecting data. So just to finish off, we are making progress with the regional and global action plan on all the strategic objectives. There's a broad collaboration within WHO, because you know WHO has both the benefit and the burden of being all over. We have global presence, regional presence, and country presence, but through coordinated action, that is really a good collaboration within the area of AMR specifically. Also with other organizations, international like FAO, OIE, but also the Commission, of course, other external partners, and increasingly with donors. We will continue to develop supporting materials on a needs basis. You tell us what you need, you tell us what is missing. Do we need support in this, templates for that, and we'll try to develop that. And of course, increasing the number of people that can actually be deployed to countries and support you in your country through experts and consultants. So with that, I'd like to thank you for your attention.
Any question? I have one. You say the GLASS protocol, based on the experience of the past years, will evolve rather than be a total revolution. Where do you see the evolution go? Less pathogens, less types of resistance, different types of samples? That would be good information even for us at ECDC.
That's true. And actually, to be perfectly honest, I don't know where that is going right now. It's a process that will start later in the year, in consultation with many partners, but also users and contributors to class. But I can imagine that it may be more targeted. I mean, my personal opinion would be that there should be maybe a smaller pool of global specimens and pathogens, and then more targeted or more tailored to the various regions in addition. But a lot of the work is done also on the platform itself, whether it should be easier for countries to share data, but also to use it as their own data management tool with sort of a country cloud where only the countries can access and play, and they then decide which part they share internationally.
That's already informative, thank you. If not, I will introduce our next speaker, Dr. Heinrich Strauss. Dr. Strauss is the Director of Antimicrobial Resistance and Healthcare-Associated Infections at the Federal Ministry of Labor, Social Affairs, Health and Consumer Protection in Vienna, Austria. And her presentation will be, so we'll have now a set of 3 presentations with country experiences, and Dr. Strauss will present the experience of Austria to implement a One Health approach to respond to antimicrobial resistance.
Thank you so much, Dominique. Sorry. I'm very happy and pleased that I'm allowed to speak to you. I was invited by Marit. She's a long-time colleague of mine, and I'm very pleased that my colleagues from the Commission, from the ECDC, from WHO, all of them who worked with us already are here, and we can have this very, very good workshop together. So I'm working in the Ministry for Health in Austria since a long time already. Before I was in Sweden, I know a little bit the situation in the northern countries. And now I will report on Austria's experiences. I will start with the history. We started actually about 2001. There was the issue that the countries should make an intersectoral coordination mechanism. This was a recommendation by the EU. So in Austria, we started to work together more intensively with the veterinary sector. Then the zoonosis directive came. You heard it already today. This was a law more in the veterinary sector, and this brought a big, big step forward for the veterinaries, but also for the humans. In Austria, we put this directive into the Austrian zoonosis law in 2005. So we had a real legal basis for many, many actions, and also for the cooperation between human, veterinary, and food sector. And then the ECDC assessment came, and you can see maybe here a person. He is also present now. If you know it, then you win a book. Who is it? It's Dominique. Dominique, I think you started at this time in ECDC your very, very successful career, isn't it? Yes, it is.
That was the summer before I joined. I was an external expert.
But he came to Austria together with a friend, and they really looked to our system. They really went to the hospitals, and we sat together and we had to discuss and we had to show them everything. It was a 1-week assessment. It was very, very heavy, very, very funny. It was very, very good. And at the end, we had a clear message for our politicians, because Dominique and his friends said, you have a very, very good situation in Austria. You have many initiatives, but you need a kind of national plan. You have to put an umbrella over all your initiatives. And you will not believe, but the politicians were convinced that is a good idea. So after they left, we started to do the plan, and then we finally got it really to the politics. Yeah, then we formed a formal interministerial platform between humans, veterinary and food sector. And then we had the National Action Plan on AMR. And now we are working this over, and now we make a very, very good plan together with the other ministries that are involved. They were not so pleased at the first beginning to work. They thought it's not our business, agriculture and environment. They just passed by, but didn't really involve. But now they're really on our table together with us, and now we make a really, really good plan. So, we have some advantages in Austria. We have a structure all in one, which means we have the human, the veterinary, and the food sector in one ministry. So for us, it's very, very easy to communicate with the other sectors. We are door by door. It's very easy for us. We have a long tradition in cooperation. We have now a formalized zoonosis platform, AMR platform, and in this platform we can work very, very close together. And based on the EU Zoonosis Directive, we did the law, and we did the Zoonosis Commission, which is a commission on national level, and we have it on every federal state level. And this is again an intersectoral commission. They deal more with outbreak investigation and so on, but we have a very, very strong AMR group. So that's another very important step. I have to speak about achievements and other things. I start with the achievements. We have done this National Action Plan. I have brought some examples here if you want to have a look. This is in German, but I have other examples in English, so it's for you. So this National Action Plan is the basis for all our actions in these three fields. So it's an intersectoral action plan. We have a digitalized reporting system for healthcare-associated infections and AMR in the human field. Actually, in the human field, it's much more difficult than in the veterinary field. Because in the human field, we don't have this EU legislation. It's a very, very weak legislation. In the veterinary field, they have a strong legislation. So they have it a little bit easier, but of course, they have much work as we. So, we have some national standards for hospital hygiene and for ASB. So that is something which is in progress. One is already installed. This means that all hospitals have to follow these standards, which is a very big achievement. We have yearly reports on AMR, on healthcare-associated infections and antibiotic consumption. So I give you now some examples what we have achieved in numbers and indicators. You have seen some of these facts already, but just to repeat. In our recent AMR report, we have that in English here in a short version. We have a quite low MRSA rate. It dropped down to 5.9. So that is, it's only an indicator. It's not the only and the best indicator, but it's an important indicator. So we are very, very happy about that. We are generally in AMR in the lower third in the EU comparison. But we have problems with gram-negative pathogens. So we have, not everything is beautiful in Austria. We are still in the average of the EU, but we have a problem. We have to work on that. In our recent healthcare-associated infection report, we have also quite good numbers. The point prevalence study shows us 5.3% overall rate, which is quite good. And in all, let's say the surgical site infection, all indicator operations, we are in a quite good field. We are in the lower third. Antibiotic consumption, we are also quite good in EU comparison. We are decreasing also in the human field, but we have as you have seen, more use in human than in veterinary field. This has turned around. This was differently. Yes, these were some numbers, and now I come to an indicator that was also already mentioned today, these dailies. Nowadays it goes a little bit more in depth concerning this AMR problem. So this is a new indicator that combines mortality and years lived with disease or disability. This is a study of the ECDC, very, very good study, was published in a very high-ranked journal. What does it show for Austria? Just to repeat, these are the daily, and you calculate it like that, very easy. And now we look to the outcome. Here is the EU average, and Austria is already, again, in a quite good field. If we look to the map, we are here, also in the lower third. But, of course, we have backslashes. Recently, I got an email from Dominic, and he said, what is going on in Austria? We have a bad result for Austria in the Eurobarometer. And surprisingly, it was right. We found ourselves in the last place when asking the questions, how did you obtain your last course of antibiotics? This is extremely surprising for us, because in Austria you need a prescription. You don't get antibiotics just by the over-the-counter. So we asked Dominic what happened here. He asked us, and we said we don't know. We asked the Commission. The Commission said everything okay. Study is okay, and it is okay. We really went into details. We thought maybe the question was raised wrongly. Maybe there was a translation problem, whatever. It is right, the study is right. And we still don't know how this result came up, because it doesn't fit to any evidence. So we have backslashes, we have to work on that, we have to find out. Maybe it's just an error, whatever, but at this point of time, you're right, it is right, and I hope we can provide you better arguments. Now to the challenges. We have problems in the political system, not really, but we have this national and federal states level. So we have 9 federal states. The payer in the healthcare system, are the federal states in the human sector. So the hospital, main player, main financier are the federal states. So we have good ideas. The national level says, yes, we should do that, and then the federal state says, okay, but we don't have the money. So here we have really a problem, and it goes very, very slow, this cooperation. There is already a good cooperation ongoing, but it is a very, very slow cooperation. Then we have problems in the legal basis in the human sector. We have currently only reporting of anonymized data for healthcare-associated infections. For AMR reporting, we have no legal basis. It's just done voluntarily. We have, for antimicrobial consumption, no legal basis in hospitals. And we cannot link prescription to therapy. We don't know why a person got this antibiotic. So here we really have problems, and we need legal basis for pseudonymisierte Daten. So, then we have another interesting problem coming up, the lawyers. Nowadays, when we go to these discussions and round tables, they don't ask us so much about the numbers, because they know they are good. But they ask us for liability. Now there is the thing going on that there should be a kind of proof reversal. So if Mr. X contracts an infection in a hospital, now the hospital has to prove that he didn't get it in the hospital. That's the wish of the patient lawyers. It's not already in the law. but they try to twist it around, which is okay, but that gives a complete new dimension. So here you see the patient lawyer of Austria. Here are some experts, you might know him, Professor Allerberger, I think you have seen him already. Here another lawyer from this patient safety platform. Here he's from the union, from the healthcare workers. And here some experts. And every year we sit then on this round table, and then we have to discuss and defeat our positions. And this was very interesting that this issue is now really on the table. So, to sum up, we have a quite good situation. We are nearly coming near to the Nordic countries, but we are very fragile. Many activities are only based on the voluntary work of enthusiastic experts, healthcare workers on the front, but not on law. So we need a stable legal basis. Now a question. When we did the presidency now, there came up the issue of this center in Denmark. We had to work through documents for the Council of Agriculture. Sorry, here this goes, yeah. And finally it disappeared. It should have been a topic on this council, but then it didn't come up. Therefore, I wanted to ask, here you on the podium, do you know what happened with this center? Yes? Would you answer the question?
This centre is under development under the leadership of Denmark, and it is established in outline. I believe that an actual work plan will be published shortly, but there's a long way to go before it's established in the way in which the vision as proposed to this council was set out.
I asked because we are so very much interested in this center, because there should then be 500 experts, 500 scientists, and we want to send some to the center from Austria. Now I come to the last part of my presentation. As you know, we have done the presidency, and during this presidency, AMR was not the topic, because it's done now by Romania. But we engaged very much in this topic, and we did many meetings on that, like the EU joint action on AMR, which was a big success, I think. So we also do much on international level. We try to work together with the international level. We did also a chief medical officer, the chief dental officer, chief nurse officer meeting, a combined meeting, also with the topic AMR, and we got Professor Bidet, to come. And he made a really, really good presentation. Our minister, she also was involved. She opened our European Awareness Day. You know, this yearly Awareness Day is celebrated on EU level, also on WHO level now, the week. And we also do it every year in Austria. This is also a possibility to bring together all different sectors. Again, it was a big event, it was a very big success, and the most important, it brought together all the sectors. So at the end, which lessons did we learn for us? And maybe you won't participate and listen to me. We learned for us, for other projects in Austria, several things. Speak with the people on the front and the scientists, from my level, from the ministerial level now. Build communities by meetings and cooperations, face to face. Here is one of these hand hygiene meetings. We started with about 50 people, 4 or 5 years ago. Now we have 150 people safe every year to come on the 5th of May. And they all interact. It's very, very successful. Yes, then involve all stakeholders, bring all them into the boat, build regional cooperations. Just one picture, because it's a very recent event. We have very good cooperations with Hungary. And just recently, you might know Ignaz Semmelweis, Saver of the Mothers. And now they put a very nice statue in our biggest hospital. And this is the president of Hungary. He came just for this event to Austria. And we want to improve now this cooperation again. It was already very, very good. Now we want to take it up. So I would say it's a very, very good idea to cooperate with the neighbor countries. Cooperate with WHO and ECDC. As you have seen in the Austrian example, ECDC was there, did the assessment, and really it was really a trigger for our national action plan. Adapt best practice models and don't reinvent the wheel, very important. Start with a voluntary approach and turn it then into legal basis. So that is for Austria. I don't know if it applies for you, but we are in this way relatively successful. Thank you very much for your attention, and I'm happy to take questions.
Thank you very much. One quick question about your issue with liability. Usually, what would secure the doctors in their practice is independent guidelines with a stamp from the ministry. So, of course, you will need a set of guidelines for everything, and that takes time. Is Austria going in this direction, or do you have other options for dealing with liability?
We are going into this direction, and we have standards and so on. And of course, but it's more tricky. It's really a tricky issue, because if it comes down to a single case, there are investigations, and we had a case in Linz with a child from Balkan, and there was a big investigation. It went well, because this child died. It came for an operation to Austria. It infected 2 other children and so on. And there was already this issue on liability. They didn't find anything from the legal standpoint. And they did whatever they could, and they had guidelines. But actually, I would say they were lucky, because also in a hospital, there can be some mistakes. And now I think the topic is on a different level. It is really going into legal cases, into much money. It gets really dangerous from this point of view. And I just realized that now, because we are not in US, but in Austria they start to move in that direction.
Sorry, a little bit on the same line. This focus on legal aspects, how does that impact on the issue of transparency of data? I mean, can you present infection rates on the internet for individual institutions when it's linked like this to kind of liability issues?
Currently, we don't have that, because there is a kind of resistance to do that, which is right, because we want quality improvement on the spot and not by a list, and we don't like to blame anybody, but the future will be that, of course. It is difficult, yes, and it's a kind of how to handle, how to balance that. I don't know, is there any country that has already this situation with listing the hospitals, and how is the situation in your country?
Well, I'll come back to it after lunch, but we are very much into the philosophy of exposing data. We're not making too much interpretations of it, and there may be reasons and so on, but basically data should be in the public domain.
I give you an example. We tried now to make the law on hospital infection data, and the federal states only accepted anonymized data. Even the hospitals, they did not like to be named. But by the new EU directive, earlier on, hospitals were like private persons treated in Austria. Now that has changed, so you couldn't give the identity of hospitals. Now it's possible, but they still don't like to do that. But I think the future will be, of course, in another direction.
Oh, okay, thank you very much indeed, Reinhild, for that really fascinating insight into what's going on in Austria, and for those, I think, very important lessons for us, not only for this afternoon, but also for tomorrow in our discussions. Now, we've reached the end of the morning, and we've got a couple of things to do over lunch. Agnia, are you going to make a short announcement about what happens next? So we will go now to have the photograph and then have lunch. And because we overran a bit, the proposal is that we reconvene here, ready to start at 1:45. That's 13:45 back here.